All right. Hello, everyone. It's me again, Decency NCLEX, the vendor of good news. And today we are here again with our guests, and we're going to be talking clinical and cultural adaptation to the United States. This is a very big topic that we have not even exhausted. We've been talking about it, trying to dissect every single thing you need to know. Guess what? This thing is just is born out of the passion to see you succeed, to make sure that when you come to the United States, you don't make the same mistakes that we made. And the best way to do it is to get a lot of people to come say almost the same thing to you, how you should get ready for that US immigration, for that very immigration and process that you've been working on. We need to get you ready. We need to make sure you have all the information that there is in this process. So here we have a very talented, very, very knowledgeable, intelligent ICU nurse. He's been an ICU nurse for more than a decade. I think it's more than going to 20 years. Or let me take it back. Maybe 18 years, okay? Because I've known him for a very long time. He's worked in top hospitals in Nigeria and here in the US. He's worked in different hospitals as well. He's based in Texas, and then he is also a travel nurse. He's been a cardiothoracic nurse as well. So he has been everywhere. He's seen it all. And one of the other places where I worked with him was in National Hospital, Nigeria, where we were part of the open heart team. So I'm an OR nurse, so we do the OR, and I work on the patient, bring out the patient, and I see myself almost every day handing over patients, open heart patients to Benson in ICU. And here we are in the United States. So Mr. Benson, you are welcome to today's meeting. It's a pleasure, such a pleasure to have you today. How are you doing today, Mr. Benson?
Well, thank you very much. The pleasure is all mine. Thank you, the organizers of this forum, the organizers of. I would say thank you very much to the CEO, the person of Decency Ogbonna, uh, the CEO of Decency NCLEX Academy, right? So. I'm really happy to be here. I'm really happy to share my journey to the US right from when it started and up to this moment. And like you rightly said, you've been in the know of the journey so far. So my name is Benson Njoagwu. If you like, I can give you my middle name. My middle name is Ifeanyi. I come from Delta State in Nigeria.
It's Igbo,
But to
right?
be precise. Uh,
I said you're Igbo.
oh, okay, if
Let's
you
not get
say
into
so.
it.
All right. So,
Uh,
I hope you guys can hear me loud and clear. Anyway, so I am a nurse. Um, I started my nursing career in Nigeria, schooled. Let me just give a brief background, right? Did my school of nursing in Agbo Delta State. I did cardiothoracic in Enugu. I worked in Lagos, worked in Abuja. Um, I used to work a lot. Back there in Abuja, I and Decency and our colleagues, we used to do like two, three jobs working in Turkish hospital, working in National Trauma Center in National Hospital. Yeah, it was a lot. You do night shift on in one hospital, you do day shift in the other hospital. Yeah, we were really hustling to not to like be really financially buoyant, but we needed to leave that country. We needed to give our family a very good future, better opportunities, you know. So let let's go through the topics that is the reason why we're here today. Today I'll be sharing my journey to the US, and we'll start with the first subtopic, which will be like the journey to the US. Then the next one will be my cultural shock, and cultural adaptation will follow, and clinical adaptation will follow. And work-life balance is next. Then my personal experiences and general encouragements. You know, I understand that all of you are in different phases of the journey. Yeah, some might be getting ready to write NCLEX, some might have written NCLEX and they will be getting ready to file their I-140, if I can remember, right?
Yeah.
I-140, and some might have had the I-140 approved. They are in the NVC stage. Some might have had their case concluded and they are waiting for interview date. Some might also have their interview scheduled and, you know, different phases. So in every phase you are, don't give up. Just keep doing it, okay? uh, the sky, the sky is going to be a stepping stone. So, um, my journey to the US, I actually came into the US using the one of the agencies. I don't know if it is appropriate for me to mention their name. Using one of the international travel agencies, I came in. The first place I stayed was in Ohio. So before we continue, let me give you a rundown of how my stay in Ohio was, and I think from there I can chip in some things that my personal experiences while in Ohio and working in a neuro ICU. My background is cardiothoracic, but coming down to the US, you can work in any ICU. You just need to have the you just need to have the 3 months practice. What was it called?
Orientation.
Orientation. You just need to have the 3 months orientation. Preceptorship was the word I was looking for. And yeah, you continue working in any ICU that you have applied for. So I landed in the neuro ICU. So the it's usually a 12-hour shift, right? It's a 12-hour shift. When you come in, you do a huddle. We call it a huddle. Like back in Nigeria, we just sit down in the nursery station and do a handover, But they call it huddle. You come together and they give brief handover before you now go to your nurse. They do the schedule. You go to your nurse. They do the assignments, rather. You go to your nurse and take a proper bedside report. So the bedside reports, you're seeing your patient, you're assessing your patient as a bedside report is going on, because they're telling you this, they did this for this patient had this and all of that, and you're seeing that patient, right? So bedside report helps us not to miss anything. Then after you have confirmed that everything the person said is what is going on with the patient, the person, if the person tells you that yes, the patient has a left or a right IJ, you're looking at the patient, you know that the IJ, that's internal jugular central line, is there, so it really gives you like um, an ongoing assessment of what you are receiving as a report. So after that, you go ahead to do your assessment of the patient. When they say head to toe assessments in Nigeria, yeah, we do head to toe assessment, but here it's in details. You go from the crown, in fact, the hair, from the hair on the patient's head down to the sole of the feet. You assess, check for any injuries in the hair, check the face, do a neuro assessment. Neuro assessment usually requires you you come in, you do like when you hear people say A and O times 4, A and O times 3, they are talking about alert and oriented times this. Um, I think that's more like a glaucoma scale stuff, right? Um, Neuro assessments on that patient requires you to ask the patient to say their name, you know, to say their name, their date of birth, and you just ask some 4 questions that will make you realize that this patient is alert and oriented times 4 or 3 or 2, or it depends on what the patient is. So uh, times 4 means that they know the situation that brought them to the hospital. They know their name. They know it's just person, place, and time. You understand? Person, they know themselves, their name. They know where they are. They know what time it is. You can ask what month are we and all that. What year are we? That's time. And situation, what brought you to the hospital? If the patient is able to answer all of that, the patient is alert and oriented times 4. So neuro assessment. Then you move on. Move on to do other um, other assessment. For instance, you can assess the face, assess the eyes, the mouth. You you do you check the lung sound with your stethoscope. So you're checking the respiratory status of the patient. Is the lung clear? Is it diminished? Are you having any rhonchi sounds? Are you having any groggy sound? Are you having any kind of sound? You have to note it, because all of these things are the things that you have to note while you are writing your report. Okay, so from there, you do abdominal sound. Is the patient having any abdominal sound? It still depends on what brought the patient. If the patient had a surgery, you check. You check the last time the patient had a BM, that's bowel movement. That's what we'll call it. I realized back in Nigeria, we usually call it bowel opening. I don't know if that's what they still call it, but here it's bowel movement. So if the patient have moved their bowel, you note it. So you check system by system, right? System by system, integumentary system. You check the patient. They just told you that the patient's skin is intact. Yes, skin is intact, but before the nurse goes home, before you certify that this patient and the nurse has given you a satisfactory report, you turn the patient to check the sacral area, checking for pressure source in those pressure points. You must check, because you see all of those things are very big. They are big deals. When they see that your patient developed a pressure sore, and you wrote that the patient's skin is intact, you'll go in for it. So after assessing your patient, doing all of the system by system assessments, then you go into the system, you go into whatever system you are using, into the computer for the patient. You check the medications that are due, medications that the patient is on. You check the fluids the patient is on. You check any orders for the doctor, any orders that the doctor must have put in. Then you know how to plan your day. You know, if a patient, sometimes patient can come with uh, diabetic ketoacidosis, and you know that this patient is on insulin drip. And this insulin drip, you need to be checking blood glucose every hour. And that blood glucose every hour, maybe another patient. Normally in ICU here, we have two patient to one nurse, unless you have one critical patient and two almost step down patients. That's when they can give you 3. Or if there are 2 critical patients, you can have one nurse to 2 patients. Or if it is highly critical, you know, they do it like a level of acuity. If it is if the level of acuity is very high, you can be with only one patient. For instance, if a patient went for an open heart surgery, you're coming back and the patient is coming back, you're going to have the patient without having another patient, So you're going to plan your day, and for instance, you have drips, like I said, insulin drip. You also have a heparin drip with another patient. You know that these are drips that you have to be very careful or with. You have to assess, you have to little things as checking pulse, checking, you see all of those capillary refill, we check, see all of those skin, that we do all of that because a patient is on heparin drip and the patient is having what is it called? The patient is having like bruises, you know that it's time to take this heparin down. You communicate with your doctor and you always check for lab. Some people do protein time PT, some do APTT, some do an anti-10 AC, something like that. It depends on the hospital. So if you are checking APTT, you check the level so that you know how to adjust your heparin. So the work sounds very cumbersome. Of course, it is cumbersome. So you have to manage your time, and at the end of 12 hours, you hand over a live patient and you go home, you know. So that might be too brief, but I'll come back to my personal experience later. So let's dive in. Journey to the US. I was I'll start by saying that coming to the US is a dream. It's a very big opportunity. The journey is something I would say for me. I don't know for any other person, but the very first day I got admission into School of Nursing was the day I told myself that I was going to travel out. Anyway, so I started working towards it from there. Not like I was writing NCLEX, no, but my mindset was already set, towards traveling out. So, um, some challenges, or let me say some of the things that you might face with the journey to US is that you're leaving, you'll be leaving your family. I don't mean like immediate family if you have a spouse and kids. No, I mean like a extended family, your brothers, your mother, your parents, and all of that. You'll be leaving them behind, and again, you're taking up the challenge of leaving your comfort zone. Do we know that the reason why some people are not able to make progress in life is that they are too comfortable with uh, their current status.
Mhm.
Then back then in Nigeria, I was with the 2 to 3 jobs I was doing. I was earning about 250,000 back in 2014, 15, 16. But somebody, a friend told me that if I'm the one that's earning as much as you, I wouldn't even think of traveling out. I say, well, our priorities and our dreams differ. So for them, they might have taken that as a comfort zone. So try to leave your comfort zone. There are opportunities that are abound elsewhere, and leave your familiar spaces. Okay. Again, you might also have some challenges of emotional and professional transition. You might be like, oh, there are some people that must have worked in a place for years. They have really emotionally attached themselves to the place. You need to break out of that. You need to break out of that attachment and make a move. Okay. Then also, sometimes doubts and some kind of excitement might creep in. You'll be like, some people have started this journey. It's their fourth year. They've not even gone. I that just started it now. Doesn't mean mine is going to take 6 years. Some of that kind of doubts. But I'm here to tell you that, see, in Philippines and India, if you check their priority dates, if you check
Bulletin.
um, their bulletin, when I came into the US in 2018, December, some of my colleagues here in the US that were Filipinos and from India, they told me they started this whole process. Some said they passed their NCLEX in 2011, in 2012. So different countries with their 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 processes, different processes. Okay, that does not mean that they won't get here. Finally, they will get here. So again, if you if you're thinking that, okay, because of the policy, policies change, governments change. Government of today might not be the government of tomorrow. So just be hopeful that someday something's will happen, and uh visas will start flying again, and you'll be in the US. Okay. And that is the resilience and the determination that will actually keep you going. So let's talk a bit about the cultural shock. When I got here, when I got here, I really felt some cultural shocks, Um, though I've worked in an international hospital in Nigeria, if some of you know it, Nizami Hospital, formerly Nigerian Turkish Hospital. But the language they speak is Turkish, right? But the English they speak is more broken than our broken English. So I wouldn't say I have worked, you know, in close proximity with people of different language than just the normal one that I was used to. But coming here, you find out that US is a capital for, I would say, the whole world. The reason I say US is a capital for the whole world is because every tribe, every country, every ethnicity, every culture in the whole world are represented here in the US. So imagine you coming to work, you're trying to really understand um, they really understand the accent of a white man. And again, their dialect differ, So you're trying to understand the dialect of a white man, and the next day you have a Chinese with the type of English they speak. The next day you see an Indian with the type of English. So you really need to try to adapt. So that was the first shock for me. And when you speak your English, your language, the English, they keep asking you repeatedly, what did you say? What did you say? What did you say? So what I finally did was make sure I speak as clear as possible. If they keep asking and I keep repeating, you know, then if they speak to you and you did not hear what they said, you ask them repeatedly, and some of them will notice it. They will say it the normal way that it is supposed to be said, right? For instance, there was a day, we were just casually talking. One of my colleagues at work, we were just casually talking. He said he likes, oh, I like honey. I like honey. I'm like, honey? What's honey? I like honey. He said it twice. He noticed that I kept, what's honey? And I said, oh, I like hunting. I'm like, I didn't say it to him, but in my mind, I was like, why did you throw away the tea? Why didn't you just put the tea so that I will understand? So communication style is going to be one of the cultural shock. that will hit anybody coming from Nigeria or from Africa, you know, at large. Um, Workplace expectations. Just like I've briefly explained, the handing over and taking over of the ICU and things that are expected to be done. Every different units have their expectations. Of course, you have to be professional when it comes to uh, handing over and taking over. You must some of them, or very few of them, but that is the standards. I don't know why some people don't do it. You have to do a bedside handing over and taking over. You know, you have to really communicate to your patients. You see, as an ICU nurse, I I have built the habit of talking to even the patient in coma. I'm telling you, you have to explain things to the patient, even if even if there's nobody there, you are just alone with the patient. You come in, you call the patient by name, Miss So 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 so. I'm nurse this. I'm going to be taking care of you tonight. I'm about to do this. I'm about to change this drip. I'm about to do this. Okay, we're about to turn you to one side because, of course, 2 hourly turning in the ICU also, just to prevent bed sore. Irrespective of the fact that in the ICU they also have sophisticated specialty beds that move the patient side to side, right? But they'll still need you to turn the patient as an added, um, you know, care and advantage, So I would say protocols, different units with their different protocols. So that's like workplace expectation. So when you come, that shock will also hit you. Be like, oh, we don't used to do a lot of this back home. Excuse me, but yeah, you have to do it and do it right. Um, Time management culture. Of course, when you're here, yes, we do have African time, Nigerian time. When you're here, you have to be time conscious. If they say something is 10, if they say the start of shift is 7:45, you're expected to be there 7:30. Okay? You're expected to be there 7:30, go through, they must have done assignments, go through your patients and see if there are any questions you will have before handover and takeover, and check, just do a report for the patient, for yourself, because sometimes when you start the shift, man, there are some days that are so hectic that you will not have chance to sit down to document. Okay, so be time conscious, be able to prioritize and delegate, if that's will really if there are people that are competent enough for you to delegate jobs to, delegate so that you'll be able to finish on time. um health Healthcare teamwork dynamics, and that is kind of very close to what we've been saying. Here, interdisciplinary teamwork matters. Back home, um, you just come to work, take over, do your thing. Sometimes you talk to the doctor, but here you communicate with the doctor, you communicate with the pharmacy, you communicate with the dietitian, you communicate with it's a teamwork. It's a teamwork. If you notice something that is not, that's why they would want you to really advocate for your patient, because if you're advocating for your patient, you go above and beyond to maintain that teamwork. You go above and beyond to get that patient what they need at the end. If when you record the patient satisfaction, is a big deal, you know. So the teamwork, like I said, interdisciplinary aspect to the stuff, like you talk to your doctors, you tell them what the patient needs, you tell them maybe a lab just resorted, you have to communicate to the doctor that so lab resorted, this is what it is. Then because you are expecting that this is the order that will follow. Then they put in the order, you carry it out. There are also some labs that does not require the doctor's order. They already put in a protocol. For instance, in the ICU, you are not expecting any doctor to tell you that you have to do an EKG or ECG when the patient is having any arrhythmia. You see that on the monitor the patient is having, for instance, let's say patient is having AFib, you know, or a flutter. You see it, and this is AFib, a flutter. Before you call the doctor, you've already done an EKG, you call the doctor, then they put in metoprolol or whatever medication they want to put in, then you go on and give and all that. So then um, learning how the system works. Of course, they are all encompassing, is a part of the cultural shock. When you come in, you really have to learn how the system works. That's why you have 3 months of preceptorship. Okay, let's move on to cultural adaptation. Uh, Fine, you've been hit with the shock, right? But you have to adapt. How do you adapt to all of that? You must understand those professional expectations. You must understand them, follow them strictly, and ask questions you um, when you are in doubt. You must always ask questions. You must be teachable. You understand? You must be teachable. You don't take that you know it all. A professor in Nigeria coming down here, just put your head down, learn, you know. Then building confidence in communication. All right, so going back to the communication aspect that we talked about during the cultural shock, when you have any communication problem with any of the interdisciplinary team, put it in writing, put it in text, put it in. The system is so organized in a way that you have places where you can make a note to anybody that works in that hospital. You put it there, and it's there in the system. If they come to kind of check the system to see if what happened, maybe an incident occurred, they will see all your documentation, they'll see all your communication with the person. So that really gives you a clear solution on how to um, attend to the problem of the communication and having a confidence in communication. You also demand that anybody that says something that you did not understand, they should repeat. They have to repeat it until you understand it. Okay. Also, you have to also realize that we coming from Africa or any part of the world, but part of the world that you have this diversity in ethnicity, diversity in language, and all of that. You have that strength in diversity because it's going to help you here. Having treated patients from um, the south side of your country, maybe those people speak different languages, and having also handled patients from the north side, outside of your country, you must have built culturally competent, attitude, or you must have been very culturally competent to deal with cases of diversity here in the US. Okay. Um, moving forward to, you know, finding a sense of belonging. Yeah, you really have to try to, find a sense of belonging because you cannot be in a unit and be the odd one out. No, you must have to blend in. Try to make everybody your friend. Try for them to understand that to understand where you're coming from, to understand your background, to understand the shocks you're facing. They really understand. What my manager told me, and one other nurse that comes from Kenya, because we were both staffed in that unit that time. What she mentioned to us one day, she said, "You guys, you guys are something else. Like you had the courage to fly from thousands of miles to a different country, to a different culture, to a different, environment, and you are doing good. That she herself cannot do that, and some of them, the whites, and some of them might just be the immediate environment or the immediate states that they were born in, that they've been working for years. Some of them don't travel, but you that is coming in, understand that you're bringing in a wealth of experience, understand that you're bringing in you know you're bringing in the different cultural mindsets that you can also teach them, and they can teach you too. you know so you have to really try to find a sense of belonging. Let's move to clinical adaptation. Now here, in the US, the healthcare here is highly structured. Here we have organizations like the Joint Commission. I think in Nigeria, do we have in Nigeria, I don't know the regulation, the regulatory organization we have there. I think it was Johesu or so, or NAM. Where sometimes they come in and check to see if everything is in order, right? So that's what these people also do. Joint Commission, and we also have regulations like HIPAA. You have to maintain confidentiality of documentation and all of that. So talking about clinical adaptation, you have um, you have your clinical, I'll call it clinical shock, okay? Because by the time you get into the hospital, you see the kind of you see the way they communicate, you see the way they assess their patient and document. Documentation is key. They document every and all, like everything. They document everything. You must form the habit of documenting. You must form the habit of documenting. You made an assessment, you put what you assess, you put what happened, you put the doctor's name you call. If you call a doctor, at the end of the call, you must you must ask the doctor the name. If the doctor mentions name that you cannot, it's not common, that you cannot spell, you can ask the doctor to spell the name, So you make your documentation and you say notified MD, so. If it has to do with nutritionist or whoever, just make sure you get the name of the person you spoke to, and you put down um, you know, the name of the person. Here also we'll be talking about evidence-based practice. Yeah, they're big on that. Evidence-based practice. If there is no evidence that this action that you're about to carry out is been proven that this action is beneficial to the patient, don't do it. Do not do it. Okay, do not do it. They are big on evidence-based practice, all right? And let's say, let's move on to colla collaboration with interdisciplinary team. We've talked briefly on that too. You have to really clinically adapt because to that particular shock, because you need the team to succeed in that unit that you are, right? Okay, you come in, for instance, in the ICU, you come in, you see that there are two orders for nutrition for a patient. One order says 20 ml of so food, every hour. Another order is counteracting and saying 50 meals of so. You have to call them, call the dietitian, call the doctor. They have to rectify it. Okay. Then you see that in uh in the medication order, you see that an order was made, and the an order was made for a medication that, for instance, hydralazine. Hydralazine was ordered for a patient that the blood pressure is, let's say, blood pressure is 160 over 110. Hydralazine was ordered. Okay. And you do understand that hydralazine also has effects on the uh, on 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 the heart rate, right? Hydralazine kind of increases the heart rate, and if any if the heart rate of the patient is above 100 already, if the patient is tachycardic and also hypertensive, you have to call the doctor to change that hydralazine to something else, maybe lobetalol and all of that. So those are the things that you make sure that you're able to work with your team, work with your fellow nurses, in harmony, work with them like professionally. Yeah, you can be able to adapt in that way. Uh, Again, let me talk on some of the gadgets that we have here. Things like a Larry's pump. Back in Nigeria, I used a lot of syringe pump, infusion pumps, but this one they have here, the Larry's pump, is used commonly in many hospitals. It is connected to the internet, right? When it's connected to the internet, you can, in the system, in the computer system, the chart for the patient, okay? The chart for the patient, from the chart for the patient, you can modify some things and it will affect the Alaris pump. You see, then on the Alaris pump, you can make some changes and it will appear in the system. So they are all interwoven, they are all interconnected. They call the entire system interoperability. So you have a lot to adapt to. So within that 3 months, you're learning pumps, you are learning gadgets, you're learning, how to collaborate with your team. You're learning that you have to document a lot of stuff. But at the end, you'll be glad you did. All right, so moving on to work-life balance. Uh, the money is good. Sometimes okay, let me take myself as an example. Though I don't do that anymore. I think have grown past that stage. But there was a time I was doing 16 hours a day, 16 hours for 12 days, 16 hours for 16 days. I was doing a lot of job. I was doing a lot, I wasn't even resting. The only 5 hours I will get when I get home is to sleep, wake up and hit it again. At some point I understood that, yeah, this could be devastating. It weighs you down. It reduces your immunity to, fight infections, especially, during seasons of flu and all of that. You can just come down with flu just because your immunity is weak. So do not make the whole money you would have made in 10 years in 1 year. The money is good, but you have to stay alive to get this money. Okay? So strike a balance between your work and your life. Make sure that you avoid burnouts. Burnout is very common in all hospitals. Burnout is common. You work, you're burnt out, you're tired, you at the end, sometimes you're depressed, you're asking yourself, what am I even doing? What is all this? Avoid burnout. Protect your mental health. Yeah, I would say that. Protecting your mental health, pro- avoid stress. Avoiding stress, just do your minimum hours in a week, and try to, if you want to pick up shift, pick up one or two times a week. You know, that evens everything out. Don't kill yourself trying to get all of the money in the US, okay? Also try to spend time with your family. That's paramount. That is very important. If you've got a spouse, if you've got children, try to spend time with them. Make sure you make that a priority, because well, just try to spend time with your family, you know. Um, make that time to go. You have dates with your family, have dates with your wife, your husband. Family time is all we have, you know. Family time is all we have, because today, if somebody drops dead, the next day they've advertised for they've advertised for the position, and you see hundreds of people will be applying for one position, coming to fill it. Life will move on. Okay, so apply caution. Um, Also, where are we now? Let's see. For the in the whole my whole experience in the US, I want to enumerate some key lessons that I've learned. The first one, the first one is that, you know, growth comes with challenges. If you bottle yourself in one position, in one situation, you don't want to move forward, you don't want to leave your comfort zone, you won't grow. Okay. And here, opportunities are bound for you to grow. Here, you have the opportunities to further your education. You have loans. Yeah, back home we are not used to it, but when you find yourself in Rome, what did they say? Behave like the Romans. So when you come here, you have to utilize it. You have to make sure that if you want a car loan, you can get it, but apply caution too. You want a student loan, you can get it, get the education you need to further your to go up the ladder in your profession. Don't stay don't stay very long on bedside nursing. Okay, bedside nursing is what kills. If you see someone that is an MP, or you see someone that's a DMP and all of that, they are not bedside, they are consultants, you know. So that's what I've learned, that growth uh, comes with challenges. And your ability to adapt is a very powerful thing. Do not ignore it. When you are able to adapt, you see yourself doing tremendously in life. Um, Also, our background is our strength. Coming from the hustling spirit back in Africa, coming from, situations that stress stress us out, and you land yourself in the US, where they say, yes, it is the land of milk and honey. You can you can really succeed. Yeah, you can succeed. Um, I want to encourage us. Like I said, we're all in different stages of our journey down to the US. We we don't have to give up hopes, especially people that find themselves in the countries where US immigration has affected negatively, or a temporary pause in some in some categories of immigration. Do not give up. Do not give up. Do not give up hope. Be determined. If you are not married, you want to get married, go ahead and get married. Continue living your life. I think if you do not have a BSc and you think you can have a BSc, just go ahead and apply. You know, just be doing things that would take off that take off that burden of, wanting to be depressed because the whole thing is not moving forward the way you would expect, right? One day it will happen. One day it will happen. Uh, the 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 ban or the whatever that has been placed, whatever that has been placed on the immigration process of some countries cannot remain permanent. It will change. It definitely will. So the immigrant journey is not an easy one. You have to build. It really makes us to build resilience and character, and also just understand that when you come to the US, your starting point is not going to determine your future. Okay, you will definitely move up that ladder, right? And again, I want to share this with us that the United States of America, that name is a brand, is a brand itself, is a brand on its own. Is the land of milk and honey. Really, I can attest to that. When you come here within the first year, unless you tell yourself that you don't want to hurry, within the first year you can buy a house. Yes, you can buy a house. Of course, you can get a car. You can buy a house. I don't mean buying a house outrightly with 500,000. No, it's on loan, of course. So you can get a house. You can continue. You can further your education, you can achieve because you're coming here. Most of us came here with a 10-year permanent resident status. Within the first 5 years, you get your citizenship, and that's like a passport to the world. You can travel the world when you get your citizenship within 5 years after arriving. You know, and it also gives your family and your children a very big opportunity. They can be wherever they want to be. You can be wherever you want to be. You can train your children in fact, it's wonderful to be here. So let's not give up. Let's be determined that to get to the finish line and continue from there, and aim higher. All right. We will entertain some questions.
Yeah. Thank you so much, Mr. Benson. This is really a thorough and in-depth knowledge. Man, I have had a lot of people come to this show every Friday, and I rarely get people that still remember the process like you do. So I really appreciate that. I want to say a very big thank you. You were really, really, you went so deep into like the process, the things that are expected at each stage. And I like how you rounded it up by telling us that this is just a phase in the process and we have to build that resilience. And I know I've been saying it to them, but coming from you, we didn't discuss that you would be saying this, but saying it just exactly the way I would say it is really something I would really want to applaud. So thank you so much for your kindness. I know it was a big sacrifice for you to be here because, as you would see, Mr.
You're
Benson
welcome.
came from a night shift, and he's here with us. He's not grumpy. He's not sad about it. He's giving out his all. And this is one very peculiar thing about all the people that come here is born out of sacrifice. This is not a paid event. Okay, that's why you guys are not paying to be here. It's a free information to as many that would receive it, because we didn't have this opportunity to hear from people who were abroad when we were back home. A lot of them were so busy to have our time. But today we have a different breed of international nurses who still remembers their home country and remembers to give back to their community and to Africa at large. So I want to say a very big thank you to you. Okay, so if anybody has any
You're
question,
welcome.
thank you so much. I appreciate you, bro. So if you have any question, please kindly, drop it at the comment section, or you can ask for the microphone and I'll give you the opportunity to ask your question. So another person is asking, please, we appreciate, please DM what if you were not able to finish documentation before handing over, what would the nurse do? So if you are not able to finish documentation before handing over, what would the nurse do?
Trust me, within the first 3 6 months of your working in the hospital, working in the US, you'll be leaving the hospital late, at least 1 hour late, definitely, because documentation is something that you always give your report, then you sit down and complete your documentation. You have to complete your documentation. If you're not able to complete your documentation, go take a computer by the side. They have computers everywhere, right? So you can go take a computer, sit by the computer and complete your documentation. Is very, very crucial. It is important. Yeah, so I remember I and my preceptor, we use as seasoned as my preceptor is as at then, and being attached to him as a preceptee, it would have been that okay, we have two people working on two people, right? Two patients, but we'll still have a lot of things that we couldn't document. So at the end, you just sit and because there are a lot of things that emergencies happen. For instance, I can remember one day I went into the patient room to assess them. They were having some kind of expressive aphasia. I don't know if you understand what I mean. You're asking the patient something and they're just saying something that is incomprehensible, finding it difficult to get the words out. So, and the patient is a neuro patient, you have to report that. You have to call for a stroke um, code. Stroke code. You have to take this patient to do a CT. If they need an MRI, you do it. Come back, then they interpret and see if the patient is having any stroke. You know, so those are the things that will keep you like away from documenting real time. But after everything, you're jotting it down somewhere. After everything, you go back and document and finish the documentation. It doesn't matter when you leave. Whatever time you leave, you clock out. They are going to pay you for that extra time.
I hope you understood that. Documentation is very, very important. All right. Please, another question from Pearl is asking, please, how do you deal or cope with colleagues that are out to sabotage your effort in the hospital, maybe just because he or she doesn't like you?
Okay, so you have every right to ask for instance, if it's a preceptor, you ask to change your preceptor, they give you another preceptor. Or if it's a colleague, it depends on what kind of what is the connection? Like, what's the relationship? Is it that the colleague is the one trying to give you a report, or the colleague within the same shift trying to sabotage your effort? For instance, uh I always use myself as an example. There is this nurse that she'll just be, she's not nosy when we're all working together, but immediately she sees that a supervisor is around, she's going to poke in every other nurse's patient to try and say, oh, this is happening, this is happening. Then you have the right to caution them. You have the right to report to the charge nurse, because there's charge nurse or charge nurses at every shift. You have the right to report to them and let them know that what this person is doing is, you don't like it. You don't like it. It's, like we'll say in Nigeria, busybody. You know, uh, you you must have reported to the doctor that so thing is happening and you are treating it already. And someone that does not even know the background to whatever is happening is coming to tell you that so your patient is this, your patient, you are not doing it. So you have to report the nurse. And you have a chain of command. You have a chain of command to make those reports. You start with your charge nurse. If you see that the charge nurse, maybe they are the same clique, because definitely, trust me, we have cliques. We have nurses cliques. Yeah, if you notice that they are of the same clique, then just wait till morning shift. If you are doing night shift, wait till morning shift to talk to your ward manager, you know, unit manager. Talk to them. Just escalation is what I'm looking for. Escalate the matter. Don't let it slide, because one day they'll put you in trouble, and it will, if you, it will be very bad if you did not speak up. Yeah,
Okay. Thank you so much, Mr. Benson. I don't know how
you're
best to
welcome.
thank you. Okay, guys, if you got value for this session of the meeting, so please on the comment section, kindly type value for me on the comment section. I think the other question was all about immigration, and I'm going to be talking about immigration on the next program. So I'm going to handle all the updates. There's a lot of updates about the U.S. immigration that I've noticed over the week, and I'm going to be giving you guys a little info about them. But on the comment section, please kindly, let's see your value. Let's see value. Let's let him know that we appreciate his time and his sacrifice for being here. I think we'll have another question. Say, what do you do have created you when you have created this so much fear of failing that you are now that it is causing you wait, let me see, that is causing you so much anxiety as a result of how you were treated by your first preceptor. I guess these people are in the US and facing this real time. So if you have already had anxiety because of your previous encounter with your preceptor, how do you handle it? Please keep the values coming, okay? We have over 100 people on the show. Please kindly keep the values coming. All right. Thank you. Benson, over to you.
One thing you have to understand is that, to really cope with that kind of situation, you do not generalize. Have an open mind. When your first preceptor hits you with that kind of attitude, and you're able to, get out of that preceptor, you get a new preceptor, keep that preceptor behind you. Whatever happened, just keep it. The only thing you have to bring forward is what you learned, you know, or what you learned from the maltreatment. Okay. And of course, you always don't always be the person to know it all, um tell yourself that you have some things to learn, whether a negative or positive situation. So whatever you've learned from that preceptor, that's your previous preceptor, let it work for you. with the current preceptor. You understand? And keep an open mind, because if you want to generalize, you may be able, you may fall into a situation whereby you are now judging the new preceptor with the old preceptor's attitude and all of that. So and it might not really go well. So get rid of that anxiety and tell yourself that you can do this.
Awesome. Awesome. Thank you so, so much. I think this will be the last question. It says, what's the difference between day shift and night shift? All right.
Okay,
So,
so um, for years now, I've been doing night shifts. I like night shift because when I come back from night shift, when everybody's awake, I'm sleeping. Okay. So, and because that is what I've been doing, I don't, I can't find myself doing day shift because I tell myself that I'll sleep all through during the day, you know. But the major differences between night and day is that during the day, they have a lot of hands, they have the team completely available. They'll have they have the primary care physicians, they have the hospitalists, they have the if it's a teaching hospital, they have the what do they call them?
the
Student
residents.
doctors, the
Mhm.
yeah, residents, they have everybody available. If it's in the ICU, they have the intensivists available, they have the respiratory therapists available, they have the not nursing heads like the managers and all of that totally available. So things can go wrong, but it's quickly nipped in the bud, you know. But at night, you don't have such um um how will I put it now? You don't have
Number
much
of people.
help, you know. So you can have the restorative therapist, but only one that is just assigned to the unit, but as against the day where all of the restorative therapists is available, you know. Then we have just in the intensivists in the ICU, you know. So, and sometimes you can have a nurse practitioner if they majored in critical care, you know, available. So the major difference is that the the is it manpower, like the number of staff, you know,
Mhm.
that you have during the day differ from the one you have during the night. That makes night duty kind of preferable for some people because you don't have a lot of people micromanaging you at night. So what I mean, of course, you know what I mean by micromanaging, but if you want me to throw more light on it, you have a lot of ego eyes, you know, looking into what you're doing during the day. But at night, it's just the charge nurse and your colleagues and the few people that are around. You do your thing yourself, and But during the day, they have a lot of people looking into. If you cough, they'll tell you why did you cough in the patient room and all of that.
Mhm.
But I'm not trying to say that day shift is horrible, but we're just trying to pick some differences here. Um. What else? Some night duties can be very tedious too and very busy. Yeah. Maybe because they don't have a lot of staff, you know. But you 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 come to work, you do your night shift, and when you get home, you sleep. When you wake up in the night, it's like your day. So we we kind of humorously when we get to work, you greet your colleagues, good morning. Everybody understand that that is not morning, but it's your own morning. You get it. Yeah,
All
but
right.
it's the same 12-hour shift. It's the same kind of one of the main differences is that during the day a lot of procedures go on during the day.
Mm, mm,
Yeah, they schedule a lot of procedures during the day, and
mm,
discharges happen a lot. You can hardly find a discharge happening in the night unless the
mm,
patient is signing against medical advice.
mhm,
If the patient is living against medical advice, that's when, okay, maybe it happened in the night. But say they are discharging the patient in the night now. So up till now, I'm not very good at the documentation that you would do to discharge a patient because I do
mm.
nights, because
Right.
I don't do a lot of discharges. Yeah,
Mhm.
so these are the differences.
Okay, all right. Mr. Benson, I want to say thank you, but and end this thing, but I have two more questions that I just wanted to use maybe like 1 minute to address, but it's two questions. So I will ask both of them. So the first one is from CY Gold, is asking, so does prolonged night shift not affect one's health? That's the first question. And then the second one is from NMA. My says, as a critical care nurse, do you advise a critical care nurse who just migrated to the United States to work in ICU? And some people say that it's horrible as a new person to start with ICU. I think Benson is a living example of a new person who came here and started with ICU. So if you can just throw a little light on these two questions, and then we'll do a little test. We'll have a language test for you. After that, we'll make you learn some languages today.
Okay,
Okay.
okay.
All right, go ahead.
The first question, if prolonged night duty affects the health status of a nurse or not. Well, there are some researches out there that tend to take towards telling nurses that too much of night shifts, or they will put it as lack of sleep. So, do you do night shift and come back and continue working without sleeping for the whole 24 hours? So that's the difference. Like they say, lack of sleep because you do night shifts. So I'm saying that lack of sleep will finally, at the end, cause people to have short-term, let me say, maybe dementia. Yeah, people have said that it causes dementia, early dementia, right? Again, some people have said that night shifts, even nurses themselves, they said the reason they changed to day shift is that they went to see their doctors and the doctor told them to stop night shift, that it causes stroke. But for me, to me, I think lack of sleep altogether is what causes that kind of stuff. If you come back from night duty, you eat, you sleep, or if you don't want to eat, you sleep, wake up, you must have rested, right? And it usually works like this. If I'm in Nigeria and it's 7 p.m. or 9 p.m., right? And I know that 9 p.m. is night time, and my body tells me that I have to sleep. What about the person that is in the US? It's afternoon. Is the person's body going to tell them to sleep? So what I'm trying to say is you you set your body to what you want. For instance, you don't sleep at night, but you sleep during the day. Your body adjusts to it. You don't sleep during the day, you sleep at night. Your body already knows that so time is time to sleep. You get it? That's why sometimes when you travel to a different time zone, you get jet lag and all of that. Those jet lag, maybe you travel to the Philippines, all these Asian countries. Um, at night you are not sleeping. They're asking you why you're not sleeping. Say you don't know, but later you realize that, oh, in Nigeria that would have been an afternoon, right?
Mhm.
Maybe that's why you are not sleeping, because you are not used to sleeping during the afternoon time. You see, your body maintains that. So it still depends on the physiological beauty of the person and what you have learned and accustomed yourself to. So I don't think it costs anything. Just make sure you have enough. That's that work-life balance that we're talking about. S- Do your job, make sure you sleep enough, make sure you rest enough, make sure you have, you have a quality time with your family and function the right way you want. The second question is what? I forgot.
Oh, just the person that was asking about critical care nursing and whether it is okay to just go into the ICU or just maybe start with other specialties with lower acuity.
Okay, so um the thing is, I would say it depends on the hospital. It really depends on the hospital and it depends on the critical care um the ICU you started with. Nobody will admit you into CVICU, for instance, the cardiovascular ICU that you'll be taking care of open heart surgeries and all that. Nobody will admit you into such ICU, coming from another country. But when you talk about like neuro, surgical, medical, you can start from there. If you want to end up with CVICU, then you work your way towards achieving that. If you don't want to do neuro, you can start with medical. Medical ICU just has to do with, just like medical surgical, right? You have the medical ICU. You just nurse patients with medical conditions that are critical, you know. But saying because you're coming from another country, you don't want ICU at you might not be able to cope in the ICU. No, back in Nigeria, my ICU experience, we don't have like restrictions to like different types of ICU, right? In Africa, you can work in every ICU, just like here too. So I worked in the National Trauma Center in the National Hospital. Those are neuro patients. And when it comes to time for open heart surgery, we do it too because I schooled in Enugu. I did cardiothoracic, right? Then in Turkish hospital, I was working in neonatal ICU. At some point, at some point, I became the favorite in neonatal ICU. They will fondly call me Papa Baby. So neonatal ICU, medical ICU, surgical ICU, cardiac ICU, CV ICU, you have all of those old experience, and you come here, you want to start with med surg. No, you want to keep that pace, you want to keep that level, you want to improve on it. Because trust me, if you leave the ICU will leave you. It's not it's, it's not a joke. It will leave you. Those skills will leave you. So when you come, pick one ICU. If you don't want to start with neuro or CVICU and all of that, just take a medical or surgical ICU and build from there. You know.
Okay. All right, ladies and gentlemen, we've come to that very time where we give our guests a test. Okay, and the test is going to be to say thank you in your very own language. We have people from different countries, so say thank you and then put the country behind it. So I would have our guests, say those words, and we'll see how best and how good you do with the language. All right, so we want to keep it coming, guys. So please, on the comment section, I want you guys to say thank you and then write the name of the dialect that you're speaking, the country where it's coming from. All right, over to you, Mr. Benson. The world is watching.
Let me start with Dewo.
Mm-hmm.
Did I get that? Dewo.
Yeah, yeah.
Well,
Uh-huh.
if it's like Igbo, it will usually be Ndewo, but Dewo.
Depends on
Well,
where in
I
Igbo,
don't
maybe
know
another
where
dialect.
the yeah. So
Okay.
the next one is that one is easy now.
Mm-hmm.
Dalurine
Mm-hmm.
is Igbo.
Okay.
Uh oh my goodness. Shukran.
Yep.
Shukran is did I
Shukran.
get that?
Yeah,
Shukran or
yeah. I
Shukran?
think you're doing well. You're doing well. Keep going. Mm-hmm.
Eshekpukpo, that's Yoruba now.
Mm-hmm.
I worked in Lagos for 2 years.
Mm-hmm. Okay. Okay.
Ah,
Let's see.
Daalụ na Chukwu gọzie gị. I got that one.
Yeah.
Imeela Chukwu
Mm-hmm.
gọzie gị. Mhm.
Mm-hmm.
Ẹ ṣeun.
There,
I
here
got that
comes the
one,
big
right?
one. Okay, let's go.
Zik Zikomo Kwambili Nyonja. Oh, that's Zambia, right?
Yeah, it's Zambia.
Zikomo Kwambili
I don't know.
Nyanja.
I don't know if you did well or not.
All right. Please, in the comment section, let me know if I did well on that. So the next one for Rita, he said Dewo. Okay. Dewo is Isoko. Oh, you see, I'm from Delta. I don't even know. And my brother is
See?
married to Robo Abi Isoko. I don't know, but I just know that he's married to yeah. But
Mhm.
but it's not Dewo. Wait, I'm trying to figure it out. Oh, okay. Let's leave it at Dewo. All right.
Okay.
Sosongo eti. This is Sosongo eti. It says Akwa Ibom.
Mm.
Sosongo eti.
I think you're doing
Mafeng.
well. Yeah.
Mafeng.
Hmm. That should be
Dareleka.
that should be Ghana.
Mafeng.
I think so. Thomas, tell us where the language is coming from. All right, then we have Presh.
Dareleka.
That should be
Dareleka.
in Suka in Enugu. I think so. I think
Dareleka. Yeah,
yeah,
okay.
maybe.
Ndewo De
Hey,
Benson.
Benson. Yeah.
De Benson.
Yeah, you got it.
Ah,
Okay, let's
Daalụ.
see. Hmm.
Daalụ rinne nna. Ẹ ṣeun gan ní Yorùbá, Nigeria. I
Hmm.
got that one.
Hmm. All right.
Imeela nwanne m.
Another Zambia, another part of Zambia.
This one is difficult. Witumezi Losi.
Western province of Zambia.
All right,
Okay,
Dalo. Oh my
okay.
goodness. Zambia,
Zimbabwe here.
Zimbabwe,
Hmm.
Zimbabwe. Okay. Maitabasa, Ekosi. Oh, Jehovah. Maitabasa, Nkosi,
Nkosi. Hmm.
Nkosi.
Nkosi. That might be Nkosi.
In Nkosi. Okay.
Hmm.
I thought maybe if it's in Nkosi, then E will not be there.
Hmm.
All right. So, Obi. Isha. Wait, I should be able to pronounce this Isha. Obilu. Obilu.
Opilu.
Obilu or Obilu. I have Asian friend,
So,
but he doesn't speak Asian.
so all this is just to tell you, thank you, Mr. Benson. There's a lot. Well, sometimes when we do this, we get a lot of languages from different places. I didn't see my Cameroonian friends. Those are other ones that will also get, their
Hmm.
own language. And I just want to say thank you, Benson. It's such a pleasure and honor having you here. And
You're welcome.
yeah, the Mafang is from Plateau Jos. I think the south
Oh.
side of Plateau.
Hmm.
All right. So thank you. God bless you. And we hope to see you again when next we call you because we will be we'll be getting you again before the year runs out. So when I come knocking, please kindly give us a listening ear.
Of
But
course, the door
yeah,
is wide open, okay?
yes, but overall, you did great today with the language. God bless you.
Right?
All right, ladies and
Thank
gentlemen,
you.
we're going to end this section and we will start the update session in a minute. Okay, just stay tuned. Thank you.